My water now.
Oh, people are still connecting to audio.
Okay.
Looks like almost everybody's ready. So welcome everybody to our last set of rounds for 2022. We have the pleasure of having Dr. Baer come and present to us again on heart failure. She is a general internist from Moncton, New Brunswick. Her interests include primary and secondary disease prevention. She has been a board member of the Canadian Association of Cardiovascular Prevention and Rehabilitation and prior president. She is currently co-chair of the Teaching and Education Working Group for the Canadian Women's Heart Health Alliance, a national organization promoting women's heart health. Welcome.
Thank you so much for having me back. And welcome to everyone. So I'm going to talk about heart failure. It is as I was saying to Kathy, it's a huge topic. So I am going to limit what I talk to you about today to mostly heart failure with reduced ejection fraction, a little bit about heart failure with preserved ejection fraction, because there are a few new things, a little bit about heart failure, particularly in women. And then because we're still in COVID, a one slider on COVID and heart failure. So we'll begin. I'm not going to talk about acute heart failure. Okay, so let's see. So I have no financial or other affiliations with commercial organizations, no disclosures. And just before we start, I would like to make my land acknowledgement. So the land on which I live is the traditional unceded territory of the Wolastoqiyik, Maliseet, Passamaquoddy, and Mi'kmaq people. Okay, so just a little bit about terminology. So we talk about heart failure with reduced ejection fraction, HFrEF, just to make it easy to say. So that's an ejection fraction of less than or equal to 40%. HFpEF, or heart failure with preserved ejection fraction, it's a big mouthful, which is above 50% or above. And then there's this mid-range 41 to 49%, which we really, it's that gray area. We don't really know. There's not a lot of studies to talk that have looked into that, and it's sort of a new terminology. So I won't really talk about that because there's really no evidence there. So the goals of therapy are to improve symptoms, obviously, to improve quality of life and functional status, to decrease mortality, and to decrease hospitalizations for heart failure. So that's what most studies are looking at. And so the foundational therapies have always been an ACE or an ARB, beta blocker, plus or minus ivabradine. We'll talk a little bit about that after, and a mineralocorticoid receptor antagonist like spironolactone. But then there are newer therapies, and that's what I'm going to talk to you about today, just an update. So that's the combo ARB and neprilysin inhibitor, or ARNI. There's only one on the market, sacubitril valsartan, or Entresto is the trade name. The SGLT2 inhibitors, which we're going to start putting in the groundwater. No, just kidding. Because they're involved in every study you see is an SGLT2. And then a little bit about a new drug called vericiguat. So before we're just going to back up a little bit. So the etiology of heart failure, what you're going to see, so North America, the most common cause is going to be coronary artery disease, ischemic heart disease. And so that's common things being common, that's the thing you're going to look at first. The recommendation really is, as far as looking at etiology just as a screen, is going to be a CBC, a creatinine, a ferritin, a TSH, troponin, a BNP, and then ECG and an echo. So everyone's going to get that. And then we're going to look at the common etiology. So when you look at coronary artery disease, so the question is going to be, do they have symptoms of ischemia, so angina or anginal equivalents? If yes, and they are a suitable candidate for revascularization, so coronary artery bypass, because we know that improves outcomes, then they would go straight to coronary angiogram. So symptoms, good surgical risk, straight to angio. If they're not a great candidate for bypass, you're not 100% sure, then non-invasive stress testing or regular stress testing or nuclear stress testing would be the next step. If they're not symptomatic and they have a reasonable or a good surgical risk, then you can either go directly to angiography or do non-invasive testing first. And that really depends on local practices, what's available, and what the local referral patterns are. If they're not suitable, if they are potentially a candidate for PCI, then you would probably do a non-invasive test, make sure that they have reversible ischemia, and then refer them for PCI. And if they're not a candidate, then they would continue with medical therapy. So that's basically the recommendations from CCS. So if they have ischemic symptoms and are good candidates, you revascularize right away. If they have a very low ejection fraction, less than 35%, and risk factors for coronary artery disease, even if they don't have angina and they're good candidates, you would send them for angiography. And then obviously, if they have evidence of reversible ischemia, on your non-invasive testing. And then this is just a whole host of other causes of heart failure, which are too lengthy to go into, but basically your history and physical are going to help you with that. So is there a family history? Obviously, if they're pregnant, if they have inflammatory diseases, if they have, thyroid disease, if they're, malnourished or alcoholics, or if they have a history of amyloid, those are the kinds of things that you'll get from your history and physical, and then you would test appropriately according to that. So as far as, again, this is from the guidelines, as far as early detection and even prevention of heart failure. So clinical assessment for risk factors, like you're going to do with anyone who's got cardiac risk factors, and treat the risk factors. If they have an ejection fraction of less than 35%, even if asymptomatic, the recommendation is to start treatment, usually with an ACE inhibitor or an ARB if they're ACE intolerant. Important is if you have patients who are overweight or obese, educating them, because obesity itself is an increases your risk for heart failure. And then obviously physical activity is important in anyone who has cardiac risk factors to prevent all sorts of cardiac problems, including heart failure. So if you look at risk factors just in general, and I'm not going to go through everything like in detail, but I am going to talk a little bit about diabetes. These again are from the Diabetes Canada guidelines, and then from some studies. So you're going to treat diabetes as per guidelines. Metformin is still #1 unless contraindicated. People are often or sometimes concerned about beta blockers. Overall, they're fine in diabetics. There's some question as to whether carvedilol maybe has less effect on glycemic control, and it's also one of the beta blockers we use for heart failure. So if you're concerned, that might be your first choice. Again, if the patient has coverage and can afford it, it's a little now it's generic, so it's not so bad. And then the next line of therapy after metformin would be an SGLT2 inhibitor, and I'm going to show you the studies to tell you why, but basically they've shown a decrease in worsening heart failure and cardiovascular death, which is actually seen in both diabetic and non-diabetic patients. For the DPP4s, there was one study with saxagliptin that showed an increase in heart failure hospitalization. So I would avoid that. The others are neutral, and the GLP ones are also neutral. They were studied in heart failure, and there was no significant difference. So again, you would use them based on glycemia, not based on heart failure. So metformin and SGLT2s. So the others, you're going to treat your dyslipidemia according to guidelines, smoking cessation, always important. And then the one thing I do want to bring up is that people who are at high risk for developing heart failure should receive for sure, an annual flu shot, and then pneumococcal. And the reason for that is that it's been shown that getting at least one flu shot was associated with an 18% lower risk of premature death from all causes and from cardiovascular disease in particular. And the earlier you got vaccinated, the lower your risk of premature death than getting your flu later in the season. So, so it's important to get your patients vaccinated early if they have risk factors for cardiac disease. Hypertension, again, is going to be treated to guidelines. You're going to use an ACE or an ARB and a beta blocker because it kills two birds with one stone. And you're in heart failure with reduced ejection fraction, you're going to avoid the non-dihydropyridine calcium channel blockers. So that's verapamil and diltiazem because they're negatively inotropic. Okay, I have a case study. I'm not sure how we'll maybe put your hand up if you want to talk, or Kathy can look in the chat. So this, just to get a little participation. So an 85-year-old referred, we're not going to say referred, she's seeing you as a family physician. She's had a 3-month history of progressive shortness of breath, some edema in her legs, a nocturnal cough, some orthopnea, and you have started her on Lasix 2 weeks ago. Shortness of breath has improved, her orthopnea has resolved, and she's now back for a follow-up. She has a history of hypertension, diabetes, atrial fibrillation. She's had peptic ulcer disease with an upper GI bleed 3 years ago, and she's got some osteoarthritis. So this is an ideal world because you've seen her 2 weeks later and she's had all these investigations. If it's anything like it is here, it would be 6 months. But in any case, for the purposes of our discussion, so her echo shows an ejection fraction of 40%. With a dilated left ventricle and left atrium. She's had a nuclear stress test, which showed no ischemia. Her ECG shows atrial fibrillation. Her heart rate's well controlled at 68. Her chest x-ray shows some mild pulmonary edema. Creatinine's 100. Her potassium's 5.8. Her sodium's 135. Her weight's about 40 kilos. Her blood pressure is okay with no significant postural drop. JVP I don't believe in, so we're going to ignore that. So she's got some crackles, a mid-systolic murmur, and then some pitting edema. So I'm going to show you all her meds. And what I want to know from you guys is what would you keep and what would you start? What would you discontinue? So you started her on Lasix 2 weeks ago. That seems to be helpful. Would we keep that or do we stop it?
I guess it depends on, I can't remember all the labs and the values from the prior page, but I guess it depends on volume status and.
Yeah, she's still a little overloaded. But better. So we're okay to keep that. Does she need hydrochlorothiazide? Anybody want to venture?
Could we quickly go back to the last page just to see the?
Yes, of course.
I'd probably keep it for now.
Okay. Potassium? Think about what you might be starting her
Right.
on.
So I guess because you'd be starting, you'd probably be reducing or stopping some of them, like the hydrochlorothiazide. Maybe you'd reduce and start adding in some ramipril or something, and then you'd be
Exactly.
taking off the potassium, and you just have to track the electrolytes to see.
Exactly right. So that's exactly. So if you her potassium is 4.8, her blood pressure is okay, not. You don't have a lot to play with. So, right, I would leave her on the Lasix because she's still a little volume overload. I actually stop her hydrochlorothiazide because then you'd have 2 diuretics and before you know it, she's hyponatremic and hypokalemic. I'd stop the potassium because you want to start an ACE. I'd probably stop her amlodipine again because you're going to start an ACE. Do you think she needs aspirin? She's got no cardiac history and no ischemia. And a history of peptic ulcer disease.
I would say since she's on the dabigatran, then no, she does not
Yeah,
need it.
I would stop. So I would stop all 4 of these because I don't think she needs any of them. And then we'll talk about what we're going to add. So she's diet controlled for diabetes and she's on rosuvastatin. We're okay with that. Her atrial fib seems well controlled and her creatinine was okay. Are we okay with metoprolol and dabigatran?
I don't use a ton of dabigatran, so I end up doing Xarelto or
Exactly. I don't think this slide was made when, yeah, exactly. I would go with the Apixaban or Xarelto, exactly. But she's on it, so we're okay. Panto for her peptic ulcer disease, I think is okay. Her naproxen, again, elderly woman with a history of GI bleeding on a DOAC.
certainly not the best option, but I guess the quality of life.
I
decisions
would
and things like that.
personally, I would stop it. It's not good for her kidneys. It's not good for her gut. And then the multitude of vitamins that people all are on. Again, I would, vitamin D and calcium, okay. The rest are kind of useless. But again, most people don't like stopping their vitamins. Okay. So we decided we're going to maintain her Lasix. We're probably going to maintain her metoprolol. Her heart rate was okay. We're going to add an ACE, right? And then we're going to stop all these other drugs. So we're going to try to simplify what she's on, but also put her on evidence-based stuff for her heart failure. Okay, so the Lasix and metoprolol are maintained. We've added a very, very small dose of ramipril. She's feeling better, still has some shortness of breath, a little bit of edema. So her creatinine has stayed stable, it was 100, it's now 101. Her potassium's gone from 4.8 to 5.5. Are you going to hold her ACE? Are you going to hold her ACE and give her some sodium polystyrene, K-exolate? Or are you going to make sure that she actually is what she's taking in from her potassium and ensure that she actually, with all those changes, she really did stop her potassium supplement. So C is really it. I somehow have checked. I gave you the answer before but yeah, so you've made a lot of changes. This small dose of ramipril, unlikely to make a big difference in her potassium. So you just want to make sure she's not taking in a whole pile of potassium, that she stopped it, and then I would repeat her blood work in a week. Okay, so we're going to go to talk about medications specifically. So obviously the big thing is evidence-based medicine. They're the cornerstone of treatment. If you look at poor outcomes, they're correlated to underutilization of medications or evidence-based medications, poor optimization, and then patient non-adherence, and then under-intensification. And this is just to show you that, with just an ACE or ARB, your mortality difference is about 38%. If you add a beta blocker, you go down to 70, you go to up to 77%. And if you add, everything, an ACE, an ARB, a beta blocker, and an ICD, you never get to 100%, but you go up to about 90% change of odds of mortality over 2 years. So it all is additive, is really what I'm trying to say. So medications don't work in people who don't take them, but they also don't work if we don't prescribe them. So if we don't prescribe them at all, if we don't prescribe them optimally, and if we don't prescribe them safely. Okay, so there have been some new changes to the medications that we're using for heart failure. This comes from the updated guidelines in 2021. So this used to be the sort of talk up until very recently. I used to say there's 3 things you need to know about heart failure: an ACE or ARB, a beta blocker, and an MRA. We can all go home. Not really, but basically it was triple therapy, and you started one and you nudged it up until you couldn't, and then you added another, and you nudged it up, and then you added another, and then you reassessed. And then if they were doing fine, you continued with triple therapy. If their heart rate was above 70, you would add ivabradine. You might switch them from an ACE to an ACE or ARB to an ARNI. And if their heart rate was less than 70, then you would switch them to an ARNI, and then you'd carry on ad nauseum. But there have been several studies that have come out recently that have looked at a variety of medications. So we're going to go through those. So there was ARNI versus enalapril. There was DAPA and EMPA versus placebo in patients with heart failure, and then vericiguat, which we'll talk about at the end. So the question is, like, where do you put all these drugs? What do you do with other therapies like digoxin? I'm not going to talk about ICD and CRT, just in the interest of time. So the first study, this is from 2014, was Paradigm. And again, not going to go through it in detail, just to let you know that this was over 8,000 patients who had an ejection fraction below 40%. They were on either, and it was enalapril versus an ARNI. And the primary composite endpoint was death from cardiovascular cause or hospitalization for heart failure. And there was a decreased risk of hospitalization for heart failure by about 21%, which was significant, decrease in symptoms from heart failure. And this just shows the significant difference. So the ARNI used to be, before it was named, was LCZ 696. So basically a positive trial, and that's what started the changes we now make if people are not controlled well on an ACE or ARB. So this is a more recent trial. So this is from 2019. And this looked at changes in BNP, and also looked at safety outcomes like worsening renal function, hyperkalemia, hypotension, and angioedema. And basically in a group of patients who were sicker, so this is hospitalized patients with class 2 to 4 heart failure, acute heart failure, and the benefits of starting the ARNI before discharge from hospital and through to the next 2 months was high. So it showed a benefit of in-hospital initiation of an ARNI after stabilization in patients who had acute decompensated heart failure, and extended the results of Paradigm. And then there was an extension, which was open label. So for patients who continued with the ARNI through weeks 8 to 12 of the study, there was a further 17.2% reduction in BNP. And then if you switched patients from enalapril to the ARNI at 8 weeks, there was a 37.4% decline. I know it's a BNP study, but it also showed lower incidence of subsequent heart failure hospitalization and cardiovascular mortality through the 12 weeks compared to those who did not cross over. So again, so that is what started maybe an ARNI should be started with acute decompensation. And that's, so basically, just a little bit about ARNIs. So they're generally well tolerated. So again, Paradigm excluded people who had a potassium above 5.2 or a renal insufficiency with an eGFR less than 30 and whose blood pressure was below 100. The important thing about switching from an ACE to an ARNI, is that you need a washout of at least 36 hours for an ACE, but you don't need a washout with ARBs, and that's to reduce the risk of angioedema. But if the reason that the patient is not tolerating an ACE or ARB is angioedema, ARNIs should not be used because they have the same risk. As I said, there's only one on the market currently, and that's sacubitril, valsartan, or Entresto. So that led to update of the recommendations last year. So an ARNI should be used in place of an ACE or ARB in patients who have heart failure with reduced ejection fraction, who remain symptomatic, who are on goal-directed medical therapy, and that's to decrease the risk of CV death, heart failure hospitalizations, and symptom. If a patient is admitted to hospital for acute decompensated heart failure, they should be switched to an ARNI from an ACE or ARB when stabilized and before discharged. And then if they're admitted with a new diagnosis of heart failure with reduced ejection fraction, they can be treated with an ARNI as first-line therapy as an alternate. And that's a weaker recommendation, but it's certainly acceptable. And again, depending on coverage and all those other things. Okay, so SGLT2s. So there's been a few trials now. So there's the DAPA heart failure and Emperor reduced studies. They showed a significant reduced combined endpoint of CV death and heart failure hospitalization compared to placebo. They were well tolerated. And importantly, whether the patient had diabetes or not, the outcomes were the same. So this is just from a meta-analysis of the two trials. So both of them showed that SGLT2s reduced the risk of cardiovascular death or heart failure hospitalization in HFrEF with or without diabetes. They were underpowered to assess the effects of cardiovascular death or all-cause death. But again, you have over 8,000 patients combined, and there was a the estimated treatment effect, was 13% reduction in all-cause mortality and 14% in cardiovascular death, and a 26% relative reduction in the composite endpoint of cardiovascular death and heart failure hospitalization. So most of that came from decrease in heart failure hospitalization. Again, led to the updated recommendation to use an SGLT2 inhibitor in patients with heart failure with a reduced ejection fraction, whether or not they have diabetes, to improve symptoms, quality of life, and to reduce heart failure hospitalization and cardiovascular mortality. So just a little bit about how, again, I've showed you this earlier, but basically the more therapies you add on, the better people do. So if you now are talking about an ARNI, a beta blocker, an MRA, and an SGLT2 compared to the triple therapy that we used to do, in a 55-year-old man, this comprehensive therapy would improve event-free survival by 8.3 years and overall survival by 6.3 years. So it is significant, the new paradigm shift in treatment with all these, yes, very expensive medications. So this has led to this talk about how should we be doing this? So it used to be, like I said, start with an ARB, you'd add a beta blocker, you'd add an MRA, maybe you'd switch to an ARNI, maybe you'd add an SGLT2. And if you do this and you up titrate and then add and up titrate and then add, it takes you over 6 months to get to target. The proposed new sequencing, again, it's proposed, but I think most people are thinking that this is the way to go, is you start with a beta blocker and an SGLT2. They don't affect blood pressure. They're well tolerated overall. Then you add an ARNI or an ACE-ARB, but depending on the patient population, and then you add an MRA, watching the potassium. And if you do this, you can actually get to target within about 4 weeks, and then you up titrate. So you add a small dose, add the dose, add this, and then you can start up titrating. So it is a quicker way to get to target. Again, expensive, but you guys know that. So again, this is just basically symptomatic heart failure with reduced ejection fraction. One of these, it's a little shopping list, but that they're all really sort of first line therapies now. So that's basically it. You're still going to add ivabradine if their heart rate is high and they're still symptomatic. We're going to talk about vericiguat in a second. Black patients sometimes don't tolerate ACE-ARB, ARNI as well. There is some data that suggests that hydralazine nitrates might work if they don't tolerate it. That's just one special population. And then, so digoxin, I'm not a big digoxin fan. It doesn't do anything for mortality. It may help symptoms if your atrial fib is poorly controlled with all the other stuff. You can consider it, but it's got a very narrow therapeutic window. In the elderly and those with renal insufficiency, it's always a problem. And so I'm not that big a fan, especially since it doesn't really, all it did in the early studies way back when was increase your 6-minute walk distance. So yeah. And then all the other stuff, by this point, you're referring patients on. So if they need an ICD. I just bring this up to show that even with all those medications, there's still an annual rate of sudden cardiac death of about 3%. So nothing is perfect. People still die of heart failure related to sudden cardiac death, even with all the best medications. And this is some Canadian data, which I thought was interesting. And it's based on prescription rates for, so beta blockers, it was 98%, MRAs was 93%, and ivabradine was the one that was low at about 46%. So this is patients who were at a heart failure clinic. I believe it was in Ontario. And they were actually being seen by people who that's all they do. They followed an algorithm, and you can see that there's still areas of improvement. So for beta blockers, about 40%. An MRA, you can see, so undertreated about 18.6%, and then ivabradine, very big under treatment. We're not, most people are, or many people are not using it, or probably not even thinking about it. I'm not sure, but it is something that's out there. Okay, a little bit about vericiguat because it is new. So it's a cyclic guanylate, soluble guanylate cyclase. I always get that. And basically, the one study that looked at this was in patients who were high risk and who were hospitalized. So they were very sick. 85% had had a hospitalization in the last 6 months. 40% were class 3 to 4 heart failure. They had high BNP levels. Their ejection fraction was less than 30%, and only 60% were even on triple therapy. But about a third of them already had ICDs. And basically, what this showed was that there was an improvement in heart failure hospitalizations, primarily. And so based on that, it should be considered in people who have worsening symptoms and are hospitalized or have had a hospitalization in the last 6 months to reduce heart failure hospitalization. And in fact, in people who had, this is just from subgroup analysis, who had really, really high, I think it was greater than some thousands, BNP, that there was an attenuated response for some reason, and no one's explained that. So just to talk about the 2 drugs that you're probably not yet using. So ivabradine, so symptomatic on goal-directed medical therapy with a heart rate above 70, it really has a minimal effect on blood pressure. It's not well studied in people with severe renal insufficiency, so I wouldn't use it in people probably with an eGFR less than 30, definitely not on dialysis. If their heart rate was above 77 in subgroup analysis, they benefited most. Can be initiated in hospital or once they're stable. There are some small visual disturbances, and obviously bradycardia can be a side effect. And then variciguate, so worsening heart failure symptoms, hospitalization within last 6 months. So people with a blood pressure below 100 were excluded. It doesn't really affect heart rate. There's not really any contraindication in renal dysfunction. We don't know about dialysis, so obviously wouldn't use it. Cannot be combined with nitrates. And then, it was 8,000. So people with N-terminal pro-BNP greater than 8,000 were unlikely to benefit. And then hypotension and anemia are the two side effects there. Okay, clear as mud. So we're going to just skip quickly because there has not been a lot of positive studies with in heart failure with preserved ejection fraction, but there is something new. So the typical person with heart failure with preserved ejection fraction is going to be, it's usually an elderly female with a history of hypertension and atrial fib, with a whole host of other potential comorbidities like metabolic syndrome, kidney dysfunction, deconditioning, COPD, et cetera. So that's your typical HFpEF patient. So really, it's the same recommendations for, doing the workup, because you need an echo to diagnose this. You're going to use beta blockers if they've got, for heart rate control, or if they've got angina or previous MI. Most patients, you're going to use an ACE or ARB. There is one study that looked at an MRA called the TopCat trial, which had a few problems, but it was positive. And so that is useful in these patients. But basically, you want to correct the underlying cause, because usually there's something, they come in either with new onset atrial fibrillation or heart rate or tachycardia because their atrial fib is not controlled, or they have ischemia, or they have a pneumonia or whatever. Yeah, it's usually, or hypertension that's uncontrolled. So often there's an underlying condition that you want to control. So you're going to treat the comorbidities, you're going to give them diuretics, and then the usual stuff. So there's been 2 trials. This is the Paragon trial. They all start with P's, but basically it was over 4,000 patients with class 2 to 4 heart failure and ejection fraction above 45% who had an elevated BNP, and it was a negative trial. So ARNIs did not reduce heart failure hospitalization or death from cardiovascular causes, but there was a pre-specified subgroup that maybe there was some benefit in women or those who had a lower EF. But if they have a lower EF, they're probably going to be on the side of that mid-range to reduced ejection fraction. So generally speaking, not much there yet. There's more studies ongoing. But the SGLT2s did show something. So this was with empagliflozin, which reduced the combined risk of cardiovascular death or hospitalization for heart failure in patients who had preserved ejection fraction, again, regardless of whether they had diabetes or not. This is called the Emperor Preserve trial. So people had an ejection fraction over 40%. So it's that sort of mid-range plus the HFpEF. So the effect was mainly on lowering the risk of hospitalization for heart failure in the EMPA group. And about 80% of these patients were on triple therapy already. So it was on a well-treated population. And so SGLT2s are probably one of the few medications that we have to lower heart failure hospitalization in people with HFpEF. So that's very encouraging. And then similar, so the DELIVER trial, which was dapagliflozin, again, in the mildly reduced, so the mid-range and preserved. And so there was an 18% decrease in the need for hospitalization for heart failure, no significant effect on mortality, with a number needed to treat of 32. So both DAPA and EMPA have positive trials for HFpEF. I'm going to switch gears a little bit. and just talk about cardiovascular, the management of heart failure in women. And I'm going to start with a case study, and then I'll present this case study. We'll talk a little bit, and then I have some questions on the case study that I'll get you to participate in. So an elderly woman, 88, lives with her daughter and son-in-law, past history of atrial fibrillation. She's had uterine cancer. She's had a hysterectomy and BSO. She has some lymphedema in her legs. She has a history of hypertension, no diabetes, no dyslipidemia. She's a non-smoker, lifelong. And she comes to the emerge with a gradual onset of some shortness of breath on exertion, orthopnea, PND, and some belly pain. She gets a diuretic. She's discharged on Lasix 80 milligrams once a day with a presumed diagnosis of heart failure. So at the first clinic visit, she's in your office now. She's feeling better. Back to her baseline functioning, no chest discomfort, no dyspnea, no orthopnea, no PND. She still has the chronic lymphedema. And she's on metoprolol, amlodipine, apixaban, and Lasix. Her blood pressure is 143/69. Her heart rate 67. It's irregularly irregular. Her lungs are clear. She's got the chronic her baseline lymphedema. Her sodium is 139. Her potassium is 3.4. Creatinine 75. And she's in atrial fibrillation at a heart rate of 70. So her BNP is 5,803 with a normal range in women up to 215. Her echo shows an ejection fraction of 66%, and she's got moderate severe mitral regurgitation. She was offered a MIBI and or a coronary angio, but she declined. Okay. So we're gonna go through how would you manage this patient, but I'm gonna come back to it after I talk to you. Okay. So women represent about 50%, 52.6% of heart failure cases, and 57.8% of all deaths attributable to heart failure. These are American data. So more than half the people who die from heart failure are women, but heart failure presents with at a more advanced age in women compared to men. So and again, another study, it's an older study, but it looked at new onset heart failure between 1981 and 2008 in the Framingham heart cohort. So about 457 out of 6,340 patients developed heart failure, had an ejection fraction documented, and about almost half were HFpEF. And when they divided this by gender, they discovered that men were more likely to develop heart failure with reduced ejection fraction, and women are more likely to develop HFpEF slightly more commonly than HFrEF. So HFrEF more common in men, HFpEF more common in women. So one of the hypotheses as to why this is the case has to do with how cardiac risk factors affect men and women differently. So that's one of the hypotheses. So for women, hypertension leads to concentric LVH, left ventricular hypertrophy, and then they go on to heart failure with preserved ejection fraction. But in men, it's eccentric LVH. And so that's why they go on to heart failure with reduced ejection fraction. So hypertension in women increases the risk of heart failure by about 3 to 4 times, whereas in men, it's about 2 times. And then for diabetes, so diabetes is associated obviously with all sorts of cardiac abnormalities. It seems to be associated in women more with changes in left ventricular wall thickness and more left ventricular remodeling than in men. So the result is that diabetes leads to a 5-fold increase in heart failure in women, but only a 2-fold increase in developing heart failure in men. So the phenotype of heart failure really looks very different in men compared with women. Men with heart failure are younger, so they're in their 60s. They usually have coronary artery disease or dilated cardiomyopathy, and that ends up with heart failure with reduced ejection fraction. And then men, their comorbidities tend to include peripheral vascular disease, tobacco use, COPD, and renal insufficiency. On the other hand, with women who have heart failure, they tend to be older in their 70s. They tend to have hypertension, diabetes, atrial fib, and valvular heart disease, which ends up leading to heart failure with preserved ejection fraction. And then some of the more common comorbidities in women who have heart failure are stroke and anemia. They're also more likely to be living alone or in assisted living residence. So again, the very first studies that looked at HFpEF did show that candesartan and an MRA, as we talked about earlier, and then now an SGLT2. So again, treating the underlying hypertension as per guidelines and adding a loop diuretic. Okay, so we're going to come back to our patient. So again, just to summarize, she's 88. She lives with her family. She's had a history of uterine cancer. She has hypertension, no other risk factors. She's has new onset heart failure, which we've determined to be heart failure with preserved ejection fraction. Her creatinine's okay, her potassium's okay, her sodium's okay. Heart rate is reasonably well controlled. And she's on metoprolol, amlodipine, apixaban, and Lasix. Her BNP is still elevated. And again, she's got LVH with a normal ejection fraction and some mitral regurg. Okay. So what are we going to treat her with? Are we going to start her on an MRA in the form of spironolactone, start her on candesartan, increase her amlodipine, instruct her to monitor her blood pressure and weights daily, and counsel her on fluid and sodium restriction? And I'm going to give you the answer after you tell me what you think, but I'm going to change the answer from what it is here because I have other thoughts. What's that?
So Dr. Higgins has put in the chat. I don't know if you see it.
No.
Okay. Change CCB to ACEI/ARB and add SGLT2I/mRNA.
Yeah. So the answer I'm going to show you is all of the above, but exactly. I would stop her amlodipine. She's already got lymphedema. It's just going to make it worse. And I would say yes, MRA, ARB, or ACE, but probably an ARB for HFpEF. Stop this and add an SGLT2. Monitor blood pressure and counsel her on fluid and sodium restriction. Right. Okay. So just to summarize this, so women account for nearly 50% of all hospital admissions for heart failure. Despite this, only 20 to 25% of women are involved in heart failure studies. And women tend to develop heart failure at an older age, more likely to have heart failure with preserved ejection fraction. Causes of heart failure most often linked to hypertension, coronary artery disease, valvular heart disease, and diabetes. Women are less likely to have ischemic cardiomyopathy, but coronary artery disease is still the second leading cause of heart failure in women. Peripartum cardiomyopathy is a rare cause of heart failure that is unique to women. We didn't talk about that because that's a whole different topic. And then the other thing that to think about in women is that some types of chemotherapy can obviously have an effect, and so they can develop heart failure later on as a result of the chemotherapy. Okay, so I'm going to ask you a few questions here on women. So which statement is true? More men than women have heart failure. More women than men have heart failure. The incidence of heart failure in men and women are equal.
Dr. Higgins put B.
Okay. Any other takers? So the answer actually is the incidence is the same. So women represent about half of incident cases of heart failure. More than half of people who die from heart failure are women, but they do present at an older age. Okay. Which statement is true? Heart failure with reduced ejection fraction is more common in women. Heart failure with preserved ejection fraction is more common in women. The incidence of heart failure with reduced ejection fraction and preserved ejection fraction is the same in women.
B.
Yes. So again, HFpEF more common in women. I've now made that point, I think. Okay, coronary artery disease is the most common cause of heart failure in both men and women. True or false?
False.
Yes. So it's most common in men, but it's the second cause of heart failure in women. Okay, true or false? Women develop heart failure at an older age than men and tend to have hypertension, diabetes, and valvular heart disease.
Dr. Higgins put true.
Yes. So women tend to be older in their 70s compared to men in their 60s. They tend to have hypertension, diabetes, atrial fib, and valvular heart disease, which leads to HFpEF. And then other comorbidities that are very common are stroke and anemia, and again, more likely to be living alone. Okay, one last slide, and then we'll open it up to questions. So just a little bit, because no talk is complete without that word COVID. But I bring this up just because I think that we're going to be seeing more COVID-related heart disease. So it's been shown now that even mild cases increase your risk for heart failure and actually stroke. The risk was seen, and this is based on a VA study, so older white males, but still risk was there even in younger patients, so age less than 65, who had no cardiac risk factors. The risk of heart failure increased by 72%, or 12 more heart failure cases per 1,000. It was worse in people who were hospitalized, but there was an increased risk even in those who were not hospitalized. If you get reinfected, your risk goes up again. And this study was just up to 12 months. It was just published not that long ago. And again, it was a VA study, but still, I think with what we're seeing with COVID and thrombotic disease and increased risks of MI, we are going to see down the road the effects of COVID-19 in more heart failure cases. And it's just something to think about in the back of your mind if someone presents with heart failure within, even within a few months after having COVID, that might be the reason. Okay, so I'm going to open things up to questions. Let's see if I can. Not sure why I can't see the chat.
Yeah, it should be at the bottom of the screen.
Yeah, it's at the top, but it won't show chat previews. It's not for some reason coming up. Maybe if I stop sharing.
Perhaps. While you're doing that, Dr. Higgins asked, what does ARB, beta blocker, SGLT2I, and mRNA cost per month?
Yeah, good question. It's obviously going to depend because it different do you have private coverage or not? And the provinces all have different agreements with the manufacturers. So I don't know the numbers. I did look up. I did see something. If anyone is doing poems through for credit, today's was about the DELIVER trial, but it was American data, and it was $400,000 per year or some crazy thing. not 400,000, sorry, 4,000, I think 4,600 or something like that. So I don't know, but the SGLT2s are still expensive. The ARNI, there's only one, it's not generic yet. I don't think. So it is also expensive. So yes, that in my mind, that is one of the biggest things that stops us, that prevents goal-directed medical therapy optimization, is going to be the cost if you don't have a private coverage. And I don't know, because again, every province is different as far as what they cover. I don't know what the Ontario rules are for coverage. What the criteria are. They are expensive.
Do you have any thoughts on, let's say you don't have an echo yet, you're doing a clinical diagnosis of heart failure and starting treatments, and so you don't know their ejection fraction. Are you trying to base therapies based on, demographics and what you expect to be the cause? Are you doing sort of a more generic approach at the start, and any thoughts there?
Yeah, I mean, if they're in heart failure and you're just in your office, like not hot, because now that they're saying that if you're hospitalized for heart failure with new onset heart failure, you should start an ARNI right off, like once they're stabilized, once you've diuresed them, you should start an ARNI, before they're discharged. So that's, if that's the case, but then you have easy access to an echo. So I assume you're asking, like, if someone shows up in your office, I'd still, again, probably start with an ACE-ARB because they're affordable and they're easy to titrate. And then, and they're covered, and probably a beta blocker. And then the SGLT2, I mean, yes, I would start that as well because it's good for both HFpEF and HFrEF. So you can't go wrong there. And it's not going to affect blood pressure. So you could start really an ACE or ARB, a beta blocker, and SGLT2 right off the bat, and then get your echo and then titrate.
Thanks.
Any other questions? Hearing nothing, I'd like to thank Dr. Bear for coming and presenting today.
My pleasure. I hope that was not too much all at once. I think most of you know most of that. And yeah, it's easy for me to tell you, to give you a recipe. It's much harder when the patient is in front of you because there are so many other circumstances that you have to take into account. And so that's always the hard part.
Thank you.
Thank you all for inviting me. And I see Victoria Smith. Say hi to Luella for me.
Thanks, I will. I'm sure she says hello back.
Where is she?
She's in Norway right now, visiting my sister.
Always somewhere. Yeah, definitely say hi.
I will. Thanks so much for the talk.
Thank you. All right. Thanks, everyone.